My name's Dr. Pretorius. I'm going to talk to you about this little talk I made called Ultrasound Survivor, Congenital Anomalies. And basically, it's a little talk that I've made for you to kind of look at two pictures and see if one of them's better than the other and whether you'd like to be that one based on all these reality television shows. This is a picture of me going body surfing in a wave, and it's just like, you know, one of the things that you've got to balance your life, and it's something I've learned about only in the last couple of years, and I just wanted to share that with you. Okay, so this is a picture, and I want you as the audience, whoever is watching this anywhere in the world on Sona World, to first look at it and think, would I rather be A or would I rather be B? And these are both anomalies of the fetus in the kidneys. So just look at it for a second. Think about what you might wish to be, whether you were A or B. Think of the possible differential, and then I'm going to tell you which is which. Okay, so the first thing you notice is that the one on the left, A, has multiple cystic components that do not connect, that are peripheral with increased echogenicity in between. That is classic picture for a multicystic dysplastic kidney. The one kidney on the other side has just a little tiny bit of dilatation, more normal looking. The patient in B has large echogenic kidneys, and I think they measured 6 centimeters, wasn't it? About 6.5 and 5.5 centimeters. And that is large for any time in gestation because a normal fetus should have kidneys that measure 4 to 5 centimeters at term. So these are large and echogenic and fairly classic for infantile polycystic kidney disease or autosomal dominant. So let me just tell you one or two things about multicystic cystic kidneys. First off, they do not function. They won't work at all. They generally involute over time. And the important thing to realize is that 40% of them have associated renal disease on the other kidney. They can have a ureterocele from like a duplicated kidney. They can have another multicystic dysplastic kidney, but if they have that, it'll be fatal because they don't function. Renal agenesis, if they don't have a kidney on the other side, then it's going to be fatal because they won't have any renal function. And then lastly, reflux. So perhaps this baby might have reflux, just a little tiny bit of dilatation, so that'll be watched. Most of these kids generally do well, so you would rather be A than B. Now, B was autosomal recessive polycystic kidney disease. And these are large echogenic kidneys. Excuse me. These are large echogenic kidneys that the babies end up with portal hypertension and often end up with liver transplants. 30% of them are affected and they end up dying as neonates. 50% of them will end up with end-stage renal disease or renal transplants in the first decade of life. And the appearance for autosomal dominant PKD is similar. So you always want to look at the mother's kidneys or dad's kidneys if you have him there as well to see if they have polycystic kidney disease. Okay, here's the next case. Would you rather be fetus A or fetus B? Well, we can see that the fetus in A has a monoventricle in the head with fused thalami. And this is very worrisome for alobar holoprosencephaly. The fetus in B has mildly dilated ventricles, so that these look like they're about 12 millimeter ventricles, and this is a case of ventriculomegaly or hydrocephalus. I guess maybe you wouldn't want to be either one, but probably most people would say B. Holoprosencephaly is a spectrum of disorders going from alobar, semilobar, and lobar. They generally have monoventricles, fused thalami. They often have facial anomalies. Hypotelorism, cyclops, meaning one eye, proboscis, which is a fleshy mass above the region of the eye that looks kind of like a nose, but it's not a nose. And they often have midline, cleft lip, and palate. Anytime you see a fetus with possible holoprosencephaly, you should think trisomy 13. trisomy 13 has polydactyly, so you want to go look at their hands and see if you can count the digits or whether they're clenched and you can't even count them. They can have large cystic kidneys that are usually echogenic. They have micronathia and congenital heart disease. Now, the other fetus wasn't so simple. It had dilated ventricles, but they were teardrop. And on this MRI, you can see it a little bit better, but it was on the ultrasound image, the teardrop parallel shape of the ventricles with elevation of the third ventricle in between. And this appearance of the teardrop is called colpocephaly, with dilatation of the occipital horns. And the frontal horns have this trident horn appearance, and that is classic for ACC. So let me go back and just show you the teardrops here on the original picture, that teardrop parallel picture of the ventricles. That's usually the one thing that we can pick up. Okay, this is another case. This is a trick case. So I just want you to look at it for a couple minutes. This trumps most people that look at it. So I think first thing you notice is that the baby on B, that this looks like a cranium with normal choroid. And indeed, this is a normal fetus, so you would rather be B. Fetus A is not the head at all. It's the chest. And this baby has bilateral pleural effusions with the spine over here to the left. Now, how do you tell the difference? Well, a cranium has calcification all the way around. An abdomen or a chest has a spine in the middle if it's transverse, but it doesn't go all the way around. So these are probably bits and pieces of the ribs, and these are the lungs, and the heart is right here in the middle. So what do you do when you think about pleural effusions? You think hydrops. Maybe this fetus has congenital lymphangiectasia with a cystic hygroma. So let's go upstairs and look and see if there's a cystic hygroma in the neck. Anytime you see pleural effusions, you should look and see if there's skin thickening for hydrops, pericardial effusion, ascites, or other markers or anomalies of aneuploidy. Okay, the next one, would you rather be A with this fetal head or B with this fetal head? Well, A is an encephalocele with a mass off the posterior part of the head, and B is a multiseptated mass from cystic hygroma and Turner syndrome. So what do I want you to know about encephaloceles? I want you to know that patients are often referred because of an elevated AFP, maternal serum AFP alpha-fetoprotein, that 75% of encephaloceles are in the occipital region in Caucasians, and 75% are frontal in Southeast Asian women. So we want to always look both anteriorly and posteriorly. And if you take folate prior to conception for future pregnancies, you'll have a risk that is the same as the general population for neural tube defects. Now, a cystic hygroma, what do I want you to know about that? Cystic hygromas are associated with aneuploidy or abnormal chromosomes in 50%, particularly Turner syndrome, as in this fetus, which is 45XO, and trisomy 21. These are often fatal, but this fetus actually survived, which is kind of unusual. And basically, if you see these cystic hygromas in the first trimester, they're more likely to be trisomy 21. In the second trimester, they're more likely to be Turner's, but they're both common. Okay, this is another trick case. So you look at the picture on the left, and then look at the one on the right. So the one on the left is an encephalocele with a mass behind it at the occipital region, so perhaps she was Caucasian. And then the one on the right is the uterus right here and the bladder with a big, huge fibroid in the LUS. So you would rather have a fibroid. This is the encephalocele on this baby. You can see that it is occipital. Okay, here's another case. Which femur would you rather have, A or B? A has an irregularity to this femur. It's not very sharp. It's kind of wrinkled. B, the femur looks normal, but when you look at the parameters here, the BPD is at 21 in 6 weeks and the femur is at 20, so it's almost 2 weeks behind. So basically a short femur. So fetus A is osteogenesis imperfecta, which is a fatal abnormality in this fetus, and fetal B has a short femur from trisomy 21.